It's Friday, the 10th of July, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from MB Medical, with and by me, Neal Tucker, once again. Are you hot as hell? I'm standing here recording this in front of a fan with the least amount of clothes on I've ever done a podcast in, and that's why we don't live stream this. What's coming up on the podcast today? 3 pieces of research. First, we're revisiting research we covered almost 2 years ago now. Nasal sprays to prevent and treat the common cold. Remember those? Well, we have longer-term follow-up data published in the BJGP this month. Is there any benefit in this intervention after 1 year? Second, in today's Lancet, a randomized controlled trial comparing Orforglipron with dapagliflozin in adults with type 2 diabetes and metformin. Which is the most effective second agent? And then finally, a bit of a curveball in the BJGP, the role of hypnotherapy for abdominal pain in children, a randomized controlled trial, no less. Then we have a special interview at the end of the podcast where I talk to Dr Liz Bancroft, a nurse consultant specialised in oncogentics, and Natalia Norori, who is interim head of data and evidence at Prostate Cancer UK. And we'll be talking about recent recommendations from the National Screening Committee on Prostate Cancer, the targeted screening programme for men with BRCA2 that's recommended, and the Transform study for higher risk men that our patients may now be invited into. NB News quickly, bit of a slowdown over the summer on courses whilst people enjoy their summer holidays. Or not, you may have decided once again that you're going to go camping, that it's a good idea because you're a complete masochist and either getting sweated out in Europe or probably rained on in Britain is a good choice of holiday. But we'll be back in September with our updated Hot Topics course. We're writing that at the moment, and all of our dozen or more other courses that we do as well, many of which being updated for the autumn as well. Of course, everything is still available online, on demand right now, and if you sign up to MB Plus, then of course all of that is included. Okay, on with the research. Let's kick off with the BJGP. Great edition this month, but this was the research that really stood out to me because it resonated with me so much when it was originally published 2 years ago in the Lancet Respiratory Journal. We've covered that on the Hot Topics course last year, and of all the topics we presented, I think this one is the one that prompted the most discussion. In case you haven't heard of it before, I'll give you a brief bit of background. The question here is very simple. Could simple nasal sprays prevent or cure the common cold? No small ask, given that nothing else has. Could this be the answer? This then was a large randomized controlled trial, something you never see in this type of intervention. Just not sexy enough, no drug company money floating around. Instead, just a great real-world, useful study conducted by the primary care research team down in Southampton. They've done lots of really interesting research into infectious diseases in primary care in the past, and this really adds to their repertoire. The study compared 4 groups. Firstly, 2 nasal sprays. Number 1, Vicks First Defense. You might have seen this being promoted in pharmacies around winter time. Then number 2, a simple saline nasal spray. They specifically use Sterimar, but I suspect all other saline nasal sprays are basically the same. Third group was no nasal spray, but access to an online educational website encouraging physical activity and stress management. Both of these are meant to positively impact our immune system. That's the theory behind those. And then finally, usual care. That's us recommending people go get some paracetamol and give them a pat on the back. In the original trial, people in the nasal spray groups used them at the first signs of developing a cold, multiple times a day for as long as they saw fit, or as a preventative treatment if they felt they'd been exposed to someone else who had a cold around them. This was a big trial, almost 14,000 patients. It's huge. It's amazing they managed to do it in the first place. Everyone was an adult and they had to have at least one risk factor that might increase their risk of adverse outcomes if they developed a respiratory illness. So something like immune compromise, heart disease, lung disease, and so forth. The primary outcome was total number of days of illness due to self-reported respiratory tract illnesses at 6 months. Both nasal sprays showed significantly fewer days of illness, down from 8.2 days in the usual care group to 6.4 or 6.5 in the saline and Vicks groups respectively. The behavioural intervention group came somewhere in the middle with 7.4 days, but that wasn't a statistically significant difference, so you can't really say it made any difference at all. So, nasal sprays reduce the duration of the common cold when used either as a treatment or as a preventative measure. No, it's not a miracle cure. We're still waiting for one of those. But if it reduces the time off of work, for example, by 25% on a population level, that really is quite significant. The authors suggest that given there's no difference in outcomes between the spray groups, then it probably isn't the fancy stuff going on in the Vicks First Defence that's actually driving that positive result, driving the benefits they've seen, but simply the action of washing liquid through the nose, removing virus, reducing that viral load. That's what's having the positive effect. Fewer side effects with the saline sprays, so it seems like that's the one to go for. And I've bought into this after we were talking about this on the Hot Topics course. I went down to Superdrug, got myself a saline nasal spray for a couple of quid. I've been using it for the past year whenever I've had a cold. Has it helped? Possibly. Does it matter what I think? Probably not, because an N=1 trial isn't very helpful. If it was, doing research would be much, much easier. Are you convinced yet? Skeptics legitimately point out this isn't a placebo-controlled trial, so the benefits could be a placebo effect. But they had the saline nasal spray as a comparator. You can't get much more placebo than that. And you had usual care and a psychosocial intervention as comparators. The participants and researchers were blinded to which nasal spray was which. So I really don't think you could do any more on that front. All right. That's the original research. That tells us all about the methodology for this new paper as well. So what's the point of this updated BJGP paper? Well, it provides us with a longer duration of data to see if the effects of the interventions were durable over the course of 1 year instead of just 6 months. And it has the benefit of ensuring that everyone would have been through a whole year cycle. So at least everyone's gone through an autumn and a winter, through the infection season, and whether this might affect the results. Well, the results remained positive for both nasal sprays at 1 year, reducing the number of days of illness from 22 in the usual care group down to 18 for both the nasal spray groups. As with the original research, there was a reduction in reported illness days with the website-only group as well, down to 19.5, but again, that wasn't statistically significant. Interesting that the number of reported illness days was substantially more than double from the first 6 months follow-up, and perhaps that does reflect going through autumn and winter when we'd expect there to be higher numbers of respiratory infections. By a year, there was a clearer delineation between the nasal sprays when they looked at secondary outcomes. Again, saline sprays seem to come out on top with the most impact on recurrence of infection, on symptom days, fewer antibiotic courses prescribed, and less reported headaches than usual care, which was in contrast to Vicks First Defence, which actually had a greater number of headaches. One limitation of the study, the adherence to the sprays wasn't that great, particularly for preventative purposes rather than treatment. And the authors speculate that if this could be improved, so could the benefits. They also suggest that using a hypertonic saline rather than an isotonic saline, I've just checked mine's isotonic. Perhaps I need to get myself some seawater, take out the seaweed first. But hypertonic saline may be more effective, as they think some of the action is likely to be due to the supply of chloride ions to the nasal mucosal cells. Don't try rubbing salt up your nose. I think that might be a bit much. The authors conclude Advice to use inexpensive and widely available nasal sprays, even when not routinely supplying them, has moderate but an important longer-term impact on the range of outcomes, including illness duration, severity of symptoms, work days lost, intention to consult health professionals in future episodes. That's a great one. That means people are going to ask us about their colds less. And a reduction in the incidence of falls in the saline nasal group. Bit speculative, that one, but the authors do give some justification of why that may be a legitimate finding. There seems to be a lot of potential positives for a really relatively simple and safe intervention. What do you think? Are you sold yet? Okay, on to our second paper in today's Lancet, hot off the press. So this is Orforglipron, let's go with that, compared with dapagliflozin in adults with type 2 diabetes and inadequate glycemic control with metformin. This is the ACHIEVE-2 study, a multi-center randomized non-inferiority open label phase 3 trial. Whew, say that without taking a breath. This is super interesting. This is the battleground for type 2 diabetes treatment supremacy, and the fighting in this area is going to be fierce. We've only just had new NICE guidelines radically changing management, introducing the idea of an SGLT2 inhibitor as joint first-line therapy with metformin in almost all patients. It's not really about glycemic management, of course, although it does help with that. It's about the renal protection, the cardiac protection, the prevention against diseases that actually kill people with diabetes. That's what the SGLT2 inhibitors offer. But here we have Orforglipron trying to insert itself as the next option after metformin. Could it be a contender? Now, if you haven't come across Orforglipron yet or watched this space, we're going to hear a lot more about it soon. It's likely to be licensed in the UK for weight management by the end of this year or early 2027. I dare say it's coming for diabetes management as well, given these papers. It's a GLP-1 receptor agonist like semaglutide, but the difference is it's a small molecule peptide, unlike semaglutide, which is a very large molecule, and as a result, it struggles to cross the gut wall. This is why we have to inject it, or as with Rybelsus, the oral semaglutide, I'm going to keep changing between the two. I haven't made up my mind what I should be saying yet. Rybelsus is a really hot topic this week because it's just been granted a UK license for weight management. But it needs to be combined with this agent called salcaprosate sodium, which is a intestinal permeation enhancer to facilitate transfer into the bloodstream. This isn't necessary with Orforglipron, so it's easier to make, it's easier to store, easier to administer, which means it should also be cheaper, although no one actually knows what price it's going to go on sale for. But as a tablet and more affordable GLP-1, it makes it feel a little bit more like our usual oral diabetes treatments. And so could it just kind of slip in there, whereas the injectable GLP-1s never quite did? This study then was a 40-week phase 3, meaning it's just one step away from gaining a license, open label randomized multi-center international trial. They recruited people with type 2 diabetes who are already on at least 1,500 grams of metformin per day with an HbA1c of 53 to 91. That's 7 to 10.5% in old units. Stable body weight with a BMI of at least 23. Participants then had one of 3 doses of Orforglipron, either 3, 12 or 36 milligrams. Those are quite large differences. Someone should point that out to them. Or dapagliflozin, 10 milligrams. They recruited 962 people, randomized equally between the 4 groups. Basically, it was 50-50 male-female. Mean age was 56, HbA1c was average 8%, and the duration of diabetes was about 8 years, and the BMI was nowhere near 23, it was 33. The primary endpoint they were looking at was change from baseline in HbA1c at week 40, and they set a non-inferiority margin of 0.3% for Orforglipron versus dapagliflozin. But don't worry, it absolutely smashed that. So the change in baseline was 0.8%, or rather minus 0.8%, because HbA1cs went down with dapagliflozin. But it was even bigger with Orforglipron, so minus 1.23% even on the lowest dose, and minus 1.50 and minus 1.58% with the two higher doses respectively, suggesting that there are benefits with higher doses, but those benefits start to top out as you go above that 12 milligram mark. So far, so good for Orforglipron, but there are some downsides. Side effects were much more common with the GLP-1s than the SGLT2s, almost 4 times the amount, in keeping what we've seen with other GLP-1 receptor agonists and that similar class of medication. Mostly mild to moderate gastrointestinal side effects, but the discontinuation rates were also much higher. So 20% if you were using 36 milligrams of Orforglipron compared with just 6% with dapagliflozin. No episodes of severe hypoglycemia in either group, which is at least something. The authors conclude that Orforglipron demonstrated superior glycemic control compared with dapagliflozin, with a tolerability profile consistent with the GLP-1 receptor agonist class, positioning it as a potential effective oral treatment option for type 2 diabetes. The reduction in HbA1c is no doubt impressive. Side effect profile, less so. But the real question here, and one this study is not set up to answer, is what about the fringe benefits? If we move on from the idea about just getting HbA1c levels lower as being the most important aspect of diabetes management, then the SGLT2 inhibitors are much better established in their additional actions. We know they reduce cardiovascular events. We know they reduce progressive CKD. Other GLP-1s, of course, have also shown similar benefits. Semaglutide or tirzepatide both have data showing that they improve cardiovascular outcomes in people with type 2 diabetes. They both have renoprotective effects as well. Orforglipron doesn't have the trial data to support this yet. It's likely we'll see positive outcomes for it in these areas. Data does already show improvements in cardiovascular risk profiles when people are on it. But this shouldn't be assumed to lead to improvements in actual cardiovascular events or end-stage renal disease. We'll need proper trial data looking at hard endpoints rather than surrogate markers, plus an attractive price point, I think, if this is going to topple our existing type 2 diabetes treatment kings and queens. Okay, on to our final paper, again in this month's BJGP, and this is a really interesting idea being explored by our GP colleagues in the Netherlands. What do we do with children who are struggling with ongoing abdominal pain? The authors argue that current approaches to managing IBS and functional abdominal pain in children, so education, reassurance, pain management rather than resolution, doesn't work that well. 50% of children apparently still report pain impacting activities after 1 year. 13% get referred to secondary care. I wonder if this concept could also be extrapolated to adults as well, which would make it an even bigger potential market. The title of the paper is Effectiveness of Hypnotherapy for Pediatric Abdominal Pain in Primary Care, a randomized controlled trial. Two interesting things in that title. Firstly, just the mention of hypnotherapy. I have always assumed, I'll be honest, that this is mostly nonsense. It conjures up images of someone lying on a couch with a watch being pendulumed in front of their face, or Paul McKenna getting people to act like a chicken on stage. None of which really promotes it as a solid medical treatment to me. Second is the idea that this is a randomized controlled trial. That's really interesting. It turns out I may have misunderstood hypnotherapy, as in this study it's been delivered not by a qualified practitioner, which would be very labour intensive on a one-to-one basis, but by home-based guided hypnotherapy, where the children listen to exercises at home, making it cheaper and much more widely accessible. There is already data to support hypnotherapy in improving pain in children with functional abdominal pain or irritable bowel syndrome from secondary care. And there's data showing non-inferiority of home-based hypnotherapy compared with face-to-face hypnotherapy. But this trial looks at something new, which is whether all of this can be helpful when delivered in primary care. So 152 children were recruited aged 7 to 17 with functional abdominal pain or IBS diagnosed by their GP. They were randomized to either the control group, which got usual care, or the intervention group, which received home-based guided hypnotherapy via a website for 3 months in addition to usual care. The primary outcome was adequate relief of abdominal pain and or discomfort at 12 months. Sadly, the primary outcome was essentially no different between the two groups. 80% of the intervention group versus 74% of the control group had adequate relief at 12 months. But there is some good news. Firstly, those figures in themselves shows that improvement rates are high even with usual care. That is good news. The other good news, particularly if you like the idea of hypnotherapy, is that it did seem to lead to earlier improvements in pain at 3 months and at 6 months, and there was lower abdominal scores across a wide range of markers compared with usual care. There may then be a role for hypnotherapy yet. The main problem you and I are going to have is where the hell do we get child-orientated hypnotherapy from? I did find one source on YouTube, a quick whiz through the 20-minute video. It didn't appear to include any pornography or backward talking demon chat or anything like that. But whether it's the right thing that's in line with what they used in this research, I've absolutely no idea. Options really seem few and far between. Perhaps this is one where I need to contact the authors and find out what they actually used. Maybe it's something that is widely available. I'll stick it on my to-do list. In the meantime, perhaps there's a gap in the market for anyone looking for a side hustle. Time to get into hypnotherapy. That wraps up the new research for the podcast, but neatly brings us on to today's interview. And this is brought to you in conjunction with Prostate Cancer UK, who have helped fund this section. And today we're going to be talking about the recent decisions on a screening programme for prostate cancer in the UK from the National Screening Committee, a little bit about what they haven't recommended and why, and a bit more on what they have recommended and how this might impact general practice. So to help with this chat, I am joined by two experts in this area. We've got Dr Liz Bancroft, who's a nurse consultant who specialises in genetics in cancer, and Natalia Norori, who's the interim head of data and evidence at Prostate Cancer UK. And I'll get them to introduce themselves first. So maybe Liz, let's start with you, and maybe you could introduce yourself for the listeners.
Hi, good morning. I'm Liz Bancroft. I'm a nurse consultant in oncogenetics research at the Royal Marsden Hospital, working with patients in the clinic who've got a strong family history of prostate cancer or a genetic predisposition to prostate cancer. And I'm also the chief nurse at the North Thames Genomic Medicine Service in North Thames.
And Natalia.
Hi, I'm Natalia Norori. I am interim head of data and evidence at Prostate Cancer UK. So I lead the team that is in charge of monitoring and analysing the evidence base that informs our strategy and decisions.
Okay, so you two have lots and lots of experience in this area. So it's great to have you along with us today. And we've been waiting for guidance on a possible formal screening programme for prostate cancer in the UK for a while now. There's been obviously lots of media interest, lots of celebrities getting involved with this. And then the National Screening Committee published its recommendations at the end of May this year. And what they didn't recommend was a full population screening programme. The reason being it felt using PSA as the starting point, as we would do in general practice, that would maybe only slightly reduce the numbers of deaths from prostate cancer, but would lead to large numbers of men being treated for cancer that may never have caused them harm. Obviously then exposing them to potential adverse effects of that treatment. So they concluded overall in the population, the benefits didn't necessarily outweigh the risks. And that's the sort of the fine balance that screening committees have to make their decisions around. But it did recommend a targeted screening program. Here it makes a positive recommendation about one specific group, which is men with BRCA2 variant. So maybe we could just discuss that as a starting point, and then perhaps we'll have a little think about some of the other recommendations and how that impacts us in general practice and our male patients. So let's start with you, Natalia. So could you give a bit more information about this targeted screening that they're recommending?
Yes, so in their final recommendation, the UK National Screening Committee recommended prostate cancer screening for men aged 45 to 61 who have both a BRCA2 gene variant and a family history of prostate, breast, pancreatic, or ovarian cancer. So this is a bit different from their interim recommendation, where they recommended in the interim prostate cancer screening for men with both the BRCA1 and the BRCA2 variant. Some of the reasons for this is because men who have a BRCA2 gene variation have a higher overall risk of prostate cancer, and also higher risk of aggressive prostate cancer when compared to those who don't have the BRCA2 gene variant. And the modeling showed that this group in particular is more likely to benefit from screening than others. This is the first time in history that a prostate cancer screening program has been recommended for a group in the UK, but most men at risk and diagnosed with prostate cancer won't actually be eligible for this program. We've had a look at the numbers, and we estimate that under this final recommendation, only a few thousand men will be screened each year. And it's a very small number compared to the number of men that are at risk. But overall, we welcome this recommendation.
Maybe I can bring in you then, Liz. The recommendation is just for BRCA2, not for BRCA1. Maybe you could talk us a little bit more around why there's a difference here. And then perhaps you could also give us a bit of a thought about how we then are going to approach this in our patient groups.
Thanks, Neil. Yes, so BRCA1 and BRCA2 are two different genes, but they're quite similar in that they both predispose to breast and ovarian cancer in women. The main difference between the two genes is that the BRCA2 gene also has a much stronger link with prostate cancer than the BRCA1 gene. We think that men with BRCA1 may have a slightly higher risk of prostate cancer, but the evidence is much less clear. Whereas with BRCA2, there's really strong evidence. There's a strong link with prostate cancer. For men who carry the gene, they have somewhere between a 30 and 60% lifetime risk of developing prostate cancer, which is really substantial. And we've got evidence from screening studies that show that screening these men and early detection is really beneficial in terms of improving potential early diagnosis and treating those tumours and catching them early, because as Natalia has already mentioned, those men are also predisposed to having more aggressive disease.
And you mentioned about early diagnosis there as a potential benefit, but do we know that, I presume, given that they've made the recommendation, that there must be a prognostic benefit as well, like mortality benefit for those men if we are screening them then?
We know from large general population screening studies that have happened internationally that, yes, if you wait 20 plus years, prostate screening generally has a mortality benefit in men in the general population. But for people with BRCA1 and BRCA2, the screening studies haven't gone on for long enough yet for us to have a really clear steer on mortality. The studies that have been done have shown very, very low prostate cancer-related mortality. So the difficulty we have with screening studies is it takes, especially when you're detecting tumours early, probably curing a lot of those cancers that you're picking up early, it takes 20, 30, 40 years to actually get good mortality data from it. So this is, Natalia will be able to speak to this, I'm sure, in more detail than myself, but this is one of the problems we have with prostate cancer screening, is having that data in quick enough time to be able to make a difference in practice.
With prostate cancer, we have seen a lot of changes in practice, and the big issue that we have right now is because, as Liz alluded, clinical trials can take years to provide results, and sometimes things are already changing in practice. So it's almost like we're always trying to catch up. In recent years, we have seen a huge increase in the availability of real-world data. So that is actually data collected from routine clinical care. So that includes NHS records. And we can use some of that evidence to look at things like risk, to look at things like treatment outcomes and overall prostate cancer patterns. But the problem with real-world data is, because it's from the real world, is that it's difficult to control for things like bias, which is something that you can do very well in a clinical trial. So in prostate cancer, the challenge is being able to actually combine and use both real-world data when it's available and data for clinical trials. We're very hopeful with the Transform trial. So that's a trial that's being funded by Prostate Cancer UK, which will be running for a long period of time and will be able to provide the definite evidence to understand the best mechanism for screening for prostate cancer. And it includes a very strong genetic component. But in the meantime, there are several studies that will be providing preliminary bits of information that can help us better understand the landscape until we have the final results from Transform.
Okay, well, let's come back to Transform in a minute, because I know that's a really interesting study, and they did make some specific recommendations about Transform as well off the back of the guidance from the National Screening Committee. Maybe, Liz, let's just come back to you. I think the issue that we've got here is that we already know that BRCA is significantly underdiagnosed. There's a lot of people out there who will have this BRCA variant who will be entirely unaware of it. And I don't have any data on this, but I suspect that's even more true for men than women. We obviously normally think about it in the context of women, and now we're sort of saying, hang on a second, this is an issue for men all of a sudden as well. So what do you think, like on a practice level, are there things that perhaps we need to be thinking about a bit more?
Absolutely, you're spot on. There's a lot of people out there that we know will be carrying these BRCA variants, but not have any idea about that until somebody in the family gets diagnosed and tested and found to have the variant. So it's how do we manage to actually find these people and have that opportunity, that window of actually offering screening and early diagnosis. I think as an NHS generally, one of the things I think we need to get better at is taking a family history and acting on that. So in primary care, it would be a really good opportunity to ask some of those questions about whether there's a strong family history of breast cancer, ovarian cancer, early onset prostate cancer in the family, and just use that as a red flag to then refer on for a discussion about genetics in those families where, alarm bells are ringing. The other group of people are people of Ashkenazi Jewish ancestry, where we know that having a BRCA variant is much more common. It's 1 in 40 people with of Ashkenazi ancestry will have a BRCA1 or BRCA2 variant. So it's those sort of high risk people with a strong family history of cancer, or people who are at higher risk of virtue of their ancestry. And if we can flag those early, then that provides that window of opportunity to test people and then get them into the right screening programs.
I think one of the issues that we'll have in general practice is that we can't directly order BRCA tests, and so patients will need to be referred through to a genetics clinic, and that may be a barrier, whether that's from workload or whether it's just restrictions on how many people we can actually send through to the clinics. I would hope that when someone gets a diagnosis of BRCA, then the genetics clinics should be doing sort of cascade testing, presumably, and they should be checking other members of the family. But of course, it gets complicated. We're all very disparate these days, aren't we? People aren't necessarily in the same area. So if you're in a different trust, then actually if you're in a different ICB, different country, whatever it may be, then that's again another limitation, another barrier to getting tested. And I suppose that's where we in general practice then maybe have a role if that kind of information gets flagged up to us. If a man says to us, one of my family members has recently been diagnosed with BRCA, then we probably need to actually act on that, because now we've got information to say, well, actually this could have a substantial effect on that person's future and there's something we can do about it.
I definitely agree with that, Neil. I think we've seen historically men in the families coming forward less frequently than their female counterparts, mainly because there hasn't been any formal screening available to men in the family. The main trigger usually for men coming forward has been if they've got daughters of an age coming up to an age of sort of late teens, early 20s, who may need to know for the sake of their daughters whether they've carried that gene and potentially passed it on to them. But there's also a lot of sort of misconceptions in the community that men cannot carry BRCA mutations still. And so it's really sort of raising that awareness that, it's 50-50 each time somebody, every time you have a baby, 50-50 chance of that mutation being passed on from parent to child. Men carry it just as much as women. And I think that's an important thing for healthcare professionals to be aware of, that if there's a BRCA mutation in a family, it's really important we test the men and the women.
Maybe let's move on a bit from BRCA now. And I think a lot of people were surprised that there was no recommendations on screening, like more targeted screening of higher risk populations, and particularly black males. We talked about that on the podcast with PCUK before, who are obviously at substantially increased risk. I just wonder, Natalia, if we could touch on that, because there was a recommendation on these high risk groups then that, yes, we're not recommending screening, but we are recommending something else. So what's the something else that is being recommended?
For Black men, there are several areas of uncertainty when it comes to the evidence base around prostate cancer. And that's because even though we have known for years that they are at higher risk for diagnosis and have also twice the risk of dying from prostate cancer, it's not that clear the stage of the disease in which they are diagnosed. So we don't really know if they are at higher risk of aggressive prostate cancer. Our view as a charity is that we think there might be, because there's evidence from the United States that actually shows that. But the UK has a unique universal healthcare system. There's nothing like the NHS. And that means that we have a specific environment for men to be diagnosed and treated. And sometimes that environment can influence risk. So the recommendation from the UK National Screening Committee was actually to gather more data to fill in the evidence gaps for Black men as much as possible. And one of the things that we are incredibly excited that's happening is that the UK has agreed to funding to expand the Transform trials to be able to invite all Black men. This is incredible because it's going to allow us to generate the evidence that we need to get us to the best way of diagnosing prostate cancer for Black men in particular. And we are going to have initial results of the phase 1 of Transform in the next few years. That can be complemented with additional work that we're doing in the charity around real world evidence. So that is using data that's already available to understand whether Black men have a higher risk of aggressive prostate cancer.
And Natalia, for people who are just not very familiar with Transform, can you just describe what type of a trial it is?
Yes, so Transform is the largest screening trial in the last 20 years, and it will test different approaches to prostate cancer screening to help us find the best mechanism for diagnosing prostate cancer for men. It's a full-on UK trial. It will be recruiting up to 300,000 men. And there are different things that are going to be tested. We're going to be testing the current prostate cancer screening pathway, but there are also going to be tests about the most promising prostate cancer screening techniques available that have not been fully tested in a screening environment. And that includes fast MRI scans, genetic speed test, and combined ways of testing all of these different approaches in a way that has never been tested before in a large screening trial. Men who are eligible to Transform will be receiving a letter. They're going to be invited to take part of the trial. It would be incredibly helpful for healthcare professionals to be aware of the Transform trial, to know that it's already underway, as patients might have some questions about it.
Yeah, I mean, I think we often get people asking us about whether they should participate in this or that trial. So yeah, having a bit of a background knowledge is going to be very helpful for us. Liz, maybe you could just talk to us about some of the practical aspects of this for healthcare professionals, including the BRCA recommendations.
Yeah, so I think for GPs seeing patients in clinic who want to talk to you about prostate cancer screening, I think essentially nothing has really changed other than for the BRCA2 carriers. I think it's important to keep that in mind, that the recommendations that have been made are only specific to BRCA2. It should otherwise always remain that sort of shared decision-making discussion about the pros and cons of having prostate screening. And obviously, thinking about those risk factors such as family history and Black ancestry in those discussions. There's been a lot of efforts to try and help raise awareness about prostate cancer through community leaders, through celebrities, through charities like Prostate Cancer UK. And so there's a lot more discussion and a lot more people coming forward to have those conversations. So I think what we don't want is to lose some of that momentum for some of the men who should be having those discussions and having that opportunity to have that shared discussion with the GP. But of course, it is very difficult, isn't it? You see somebody with a family history. How should you then signpost them on? There's regional genetic services in all the regions across England, and then Scotland and Wales have separate systems, and they will all accept referrals for people with family history that meet criteria. There are really quick checklists on all of the local genetic services to say what criteria people would need to meet to be referred to that service. And if an inappropriate referral is made, it usually would come back with advice about why they perhaps didn't meet those criteria. And in any doubt at all, just contact your local genetic service.
I mean, I think that's a really useful point is that the onus is not all on general practice. Certainly having support from our genomic services is going to be really, really important here. Okay, Natalia, last question to you then. What is next then for healthcare professionals?
I just want to acknowledge that this is an area where we have a lot of uncertainty. And at Prostate Cancer UK, we're actually trying to reduce that uncertainty and understand what the implications of these future screening programs will be for healthcare professionals, men, and the wider healthcare system. We are also, it's a lot to take on, but we're working very hard to really bring clarity and understand what next steps should be. In the meantime, if you have any questions about the final recommendation or the implications of this future screening program, please go into Prostate Cancer UK's resources side of the website. In there, you're going to be able to add your questions around the UK National Screening Committee decisions, and we'll make sure to get back to that with future educational resources.
Fantastic. And I'll put the link to that in the podcast description. So if you do want to go into a bit more detail, then just click through from the link and that'll take you straight there. So that's really been very interesting today. Thanks so much for joining us, Liz and Natalia. I'm sure we're going to be talking a lot more about this over the next few years, and especially as we get that information from Transform. And I know there's other studies that are going on that Liz is a part of as well. There's going to be more and more for us to think about. So thank you so much.
Thank you, Neil.
Well, that really does wrap up the podcast now. So thanks for listening once again, everyone. We'll be back in 4 weeks' time. Remember, you can always get in touch. You can email hottopics@nbmedical.com. You can find us on social media as well. I hope you survive and even enjoy the heat. Until next time, look after yourselves. Bye-bye.